Welcome back, everybody. I hope you enjoyed the various poster sessions and the fireside sessions that we have just been running. Really interesting discussions again during those. Well, now it's time for our plenary session, which has the very appropriate title of the Inequality Pandemic. And of course, this is a very timely session because of course, there has been great inequality in how the coronavirus pandemic has impacted and continues to impact different groups at both a global and national level. These inequalities apply to cases, deaths, vaccine coverage, and social and economic impact. So how can they be addressed? What can scientists, public health professionals, researchers, epidemiologists, and medical practitioners do to reduce them? Well, they are just some of the questions that will be tackled now during this final plenary session of today. And it's going to be chaired by three members of the EPIET Scientific Committee. They are Stine Nielsen, a Danish infectious disease epidemiologist living in Madrid. She is the current vice president of the EPIET Alumni network, which began more than 25 years ago and which brings together more than 700 people trained in applied epidemiology and public health microbiology. Our second chair is Mircea Popa, microbiology professor at the Davila University of Medicine and Pharmacy in Romania. And finally, our final chair is Frode Forland, the Director of Infectious Disease Prevention and Control at the Norwegian Institute of Public Health. They will then invite and introduce their panelists. So we are very much looking forward to your session, and I'm going to hand over to you now.
Thank you. Thank you very much, Karen. Hello, everybody. Very warm welcome to this session where we hope to inspire you to think about and maybe also act differently upon what we as public health professionals can do about tackling the inequalities related to infectious diseases, be it COVID-19 or others. Many of us as public health professionals working at national, subnational or international public health organizations are concerned about what to do to better tackle inequalities. The COVID-19 pandemic has exacerbated several inequalities related to income, ethnicity, gender, age, and other factors. Many of us are frustrated about why we're still struggling to get these issues right. We really hope that this session will inspire you and give you some ideas or concrete examples about what we as public health professionals can do in this area. So we hope that this will be an interactive session with input from you in the audience. I think we've seen in some of the previous plenaries and sessions in the conference that most people in the audience have really participated, and we hope you will do the same for this session. There is the live discussion box where we ask you to put your questions, and we will do our best as chairs to get through as many as possible. In this plenary, we have invited three excellent speakers who will start us off by giving three relatively short, maximum 10 minutes, so-called provocations, presentations to set the scene with some of their experiences working on tackling health inequalities. After the three presentations, we will first give each of the speakers a chance to elaborate or comment on some of the points made by the other speakers, and then we'll open the floor to the audience. But please feel free to post your questions as we go. So I will start by introducing our first speaker, who is Rossalina Latcheva, who works for the EU Agency for Fundamental Rights. Now, I must admit that until very recently, I wasn't aware that we had an EU agency for fundamental rights. And I'm really looking forward to Rossalina telling us about the work that they do on tackling health inequalities. Rossalina has a PhD in sociology, and she held a postdoc position at the University of Zurich before she joined the Fundamental Rights Agency. Her areas of expertise include equality and non-discrimination, racism, xenophobia and related intolerance, migration and integration, gender-based violence, and mixed methods research. Rossalina, we are very pleased to have you with us, and the floor is yours.
Thank you very much, Stine. You can even move to the first slide. Thanks a lot for helping me to do that. On behalf of the EU Agency for Fundamental Rights, I would like to thank the organizer of this ESCAID conference for inviting the Fundamental Rights Agency to this most relevant and timely online event to provide you with some insights or provocations related to the coronavirus pandemic and fundamental rights. But before I do this, for those of you who never heard of FRA, I would just like to mention that FRA, located in Vienna, is one of the over 40 decentralized agencies of the European Union. It was founded in 2007 through a council regulation with the mandate first to provide assistance and expertise on fundamental rights issues to the European Union institutions and the member states when they implement European Union law. Second, to collect, record, analyze, and disseminate relevant, objective, reliable, and comparable data on fundamental rights issues. And third, to promote dialogue with civil society in order to raise public awareness on fundamental rights. In the absence of data on fundamental rights issues in many EU member states, FRA conducts primary data collection through EU-wide quantitative surveys as well as qualitative research with a strong comparative focus, strengthening equality and non-discrimination, as well as combating racism, xenophobia, and related intolerance, including hate crime, through the systematic collection and use of equality data are high on the agenda of the agency. In relation to COVID-19 pandemic, between April and November 2020, FRA published a series of 6 bulletins looking at the impact on fundamental rights of the COVID-19 pandemic across the EU and the measures to contain it. Why we have done that? It became quickly apparent that the pandemic and measures to contain it posed an unprecedented challenge to fundamental rights across all areas of life. We wanted to collect data to help policymakers to make evidence-based decisions that are compliant with fundamental rights standards, but also highlight promising practices. Data collected by our network of in-country researchers, so we collected it through the so-called FRANET network. The bulletins had the same structure and thematic focus. The bulletin 1 to 6 collected information on the pandemic's impact on fundamental rights, impact on daily life, and on particular groups in societies. In addition, Bulletin 2 had a specific focus on contact tracing apps. The third one considered how the pandemic has affected older persons. The sixth one addressed the impact of the pandemic on social rights. And the fifth one looked specifically at the pandemic's impact on the rights of Roma and travelers. Number 7 focused primarily on vaccine rollout and equality of access, and this was the only one that has been done in 2021. There are additional FRA outputs. The Fundamental Rights Report Focus chapter from 2021, which was published in June, looked specifically at the coronavirus pandemic on fundamental rights in a year of review. And the upcoming Fundamental Rights Report, which is going to be published in June next year, is going to look at social rights and equality in light of the recovery from the pandemic. So the next slide. I will just whistle stop through some of the main findings concerning daily life and particular groups. Info on other issues can be found in the reports. They're easily accessible on the webpage of FRA, and I'm happy to expand in the Q&A session later. So if we look at healthcare, shortages of hospital beds and trained staff to treat COVID-19 patients, there were reduced access to other healthcare services. For example, in Romania, the number of hospitalized cancer patients dropped by 46% between 2019 and 2020. In Finland, at the end of August 2020, around 140,000 patients were waiting to receive non-urgent specialized healthcare. The pandemic has put a lot of pressure on healthcare workers as well, threatening their rights to life and health. Healthcare workers have been the most infected community during the COVID-19 pandemic, as the World Health Organization reports highlights. In Ireland, for example, healthcare workers exceeded 20% of total number of COVID-19 infections as of the middle of October 2020. Several COVID-19 hospital units in Romania temporarily suspended their operations because so many medical workers were either sick or in quarantine. Reports of burnout among medical staff emerged in Latvia. If we look at the area of education, the sudden transition to distance learning affected the education of all children. Educational systems were not prepared for such swift transition to home care and distance learning. They often lacked the necessary digital infrastructure of training. Fewer than 40% of educators felt ready to use digital technologies in teaching. Remote learning presents particular challenge to children from disadvantaged backgrounds. The European Commission highlighted that many low-income homes have no access to computers, and broadened access varies widely across the EU depending on household income. If we look at the area of work, rapid rise in unemployment rates, especially for young people. Governments put in place extensive support programs, but particular challenges remain for certain groups. Women particularly affected in terms of work-life balance and carrying responsibilities, and by increased levels of unemployment. If we look at the justice system, many proceedings moved online, but long backlogs remained. Prioritization was given to cases concerning vulnerable groups, example, guardianship proceedings or cases of domestic violence. So the key message, nearly all rights set out in the EU Charter of Fundamental Rights were affected, including the right to the integrity of the person and the prohibition on selecting persons when practicing medicine and biology, including the right, the prohibition of discrimination, the right to education, rights related to labor market, and rights to healthcare for reasons other than COVID-19, including mental health. Then to the next slide, if we look at the particular groups, what did we find? The pandemic particularly affected the rights of children, the rights of older persons, especially those living in institutions, the rights of persons with disabilities, and as well as the equal access to rights of vulnerable groups of the population, such as Roma, refugees and migrants or homeless people. Moreover, it had implication on people's access to justice and their right to an effective remedy and fair trial. If we have a look at closely at children, just to highlight some of the results, the digital divide causes, as I said, unequal access to education for children in disadvantaged situation. For older people, there was experiences of loneliness, difficulties using digital tools to stay in touch, but also to access services and to access medical treatment. Just an example from a survey in Belgium showed that since the lockdown, people over 65 years of age are less likely to consult a doctor. 13% of when compared to younger age groups, for example, 28 to 29% of persons aged between 25 and 44 years of age. If we have a look at persons with disabilities, they experience reduced access to support services, also access to education for children with disabilities. The fear of infection was higher, and also the online format very often inaccessible. Situation exacerbated for people in institutional settings. High rates of deaths and infections, the impact of the visiting bans were tremendous. If we look at migrants, asylum seekers, refugees, and detainees, increased risk of infection because of overcrowded accommodations, lack of access to hygiene facilities, clean water, masks, and difficulties related to social distancing because of overcrowded accommodations. Then also rising poverty and unemployment rates for these particular groups. Looking at the biggest ethnic minority in Europe, Roma and travelers, particularly affected by restrictive measures and targets of hate speech, example of specific restriction targeting specific areas with large Roma populations, also issues associated with poor living condition, access to education. They became very often victims of racist and xenophobic language on social media and sometimes from politicians as well. Looking at domestic violence, increased in incidents, also affecting children. There were issues of underreporting, but also positive developments like new support systems. Data released by the Croatian police in June showed an increase in domestic violence misdemeanors in criminal offenses of 37% and 57% respectively in the first 3 months of 2020 compared with data for the same period in 2019. If we move to just overall as a conclusion for that part, the pandemic does not affect everyone equally, and it exacerbated already existing challenges and inequalities. If we move to the next slide, looking at the process of vaccination, in view of the shortage of COVID-19 vaccines, member states prioritized groups for vaccination at high risk of severe complications or death from COVID-19 and people who were highly susceptible to infection because of their work critical to maintaining essential services, exposed them to the virus to high extent. In practice, this translated into prioritizing for vaccination older people, especially those living in long-term care facilities, people with underlying medical conditions who are more likely to develop a severe form of disease, and frontline health care workers or staff of long-term care facilities. The focus on these 3 groups, although of relevant, sometimes led to overlooking other at-risk groups. For example, only 1/3 of EU countries classified detainees as a priority group, despite an increased risk of infection due to crowded living conditions. Not all EU countries adhered to international guidance on prioritizing vulnerable groups such as Roma and travelers, homeless people, or those with drug dependencies, particularly during the first phase of the vaccine rollout. Prisoners, homeless peoples, asylum seekers and irregular migrants who are often not covered by national health scheme face difficulties accessing vaccines. But some countries waive the formal requirement of having a social security number, for example, to get vaccinated. Regarding information on vaccination rollout, countries rarely provide disability inclusive and accessible information for people with disabilities or in different languages for those who do not speak the national language well, like migrants or ethnic minorities. There are a few examples on the slides that follow up, but I would suggest to just to show them very quickly, like measures that reached out or were targeting Roman travelers, to increase the vaccination rate for these specific groups, like in Ireland and Slovakia. Then also for the next slide, measures tackling the challenges that older people face when trying to access vaccines. There, just to mention one good practice to increase the vaccine uptake by older people in Estonia, where the government offered people aged 18 and over the opportunity to get vaccinated when they accompany a person over 70 to get the vaccination or to get to the vaccination location. So this is one example. Then the next slide is showing some practices practices that ensure access to vaccines for people without a social security number, like in Greece, Portugal, and Cyprus. And the slide 9 is showing out the vaccination rollout communication, where, of course, also countries tried to tackle online disinformation with particular measures, which is kind of nice to underline. Then my last slide are the main takeaways. Some takeaways from fundamental rights perspective. Restrictions on rights are legitimate to preserve the right to life and to health, but they must be legal, necessary, and proportionate, and when no longer needed. It is important that restrictions are closely monitored, because also now we are facing new restrictions. Important that case law is emerging, but also a scrutiny from national human rights bodies, civil societies are of crucial importance. Responses to the pandemic rooted in fundamental rights are likely to be more sustainable and maintain public trust, crucial for ensuring that people continue to adhere to the measures and also get vaccinated as well. The pandemic is worsening and continues to worsen existing inequalities in our societies. Older people are much more likely to experience serious cases and unfortunately die. There is evidence that people from minority ethnic groups have higher infection or death rates, but also that people in more precarious employment struggle to access government support schemes, those already reliant on public services most affected by restrictions on provision. We need to ensure that the policy responses reflect the specific needs of different parts of the population. We need targeted measures. And just to end that discussion, it is important that by accelerating the process of digitalization of our societies, the pandemic also revealed how important it is for that purpose and for equality to ensure that everyone has access to the internet and appropriate digital equipment and is able to profit from technological developments, even in accessing health. The last point is, and I finish with this, without a regular collection of equality data, we cannot counter inequalities in any area of life. What I would like to say with this is, if we do not measure inequality, we cannot fix it. But this has, of course, to be done in full respect of the existing data protection regulation. Thank you.
Thank you very much, Rossalina, for this very rich introduction to the session, really showing the wide scope and also with good examples from many countries, pointing to the fact that the pandemic has increased underlying inequities in societies that were already there. And I also picked up these last words, which we have used several times in Norway as well. Restrictions have to be legal, necessary, and proportionate. And that's really a question also to discuss when we are in the situation now with also a widely vaccinated population. We'll come back to you with more in the discussion time. And it's now my joy to introduce the next speaker, who is Kevin Fenton. Professor Fenton has worked in a variety of public health roles across government and academia in the UK and internationally, and most recently taking a leading role in the London's response to the COVID-19 pandemic. Professor Fenton became the Regional Director for London in the Department of Health and Social Care's Office for Health Improvement and Disparities in October 2021. He is also the statutory public health advisor to the Mayor of London and the Greater London Authority. He provides leadership across London for health, prevention of ill health, and also health protection and reduction of health inequalities. In spring 2020, he oversaw the National Public Health of England review on disparities in risks and outcomes of COVID-19 and published the groundbreaking report called Beyond the Data, which I think is partly what you will be also telling us about and what you have been doing to try and reduce these inequalities in London. Professor Fenton, the floor is yours.
Thank you very much, Frode, and good evening, everyone. It is such a pleasure to be here with you at Escaida, and I'm looking forward to the conversation today, because one of the things we know is that inequalities have been a defining characteristic of the evolution of the COVID-19 pandemic within our region, within our countries, and within our communities. And the solution for getting out of the pandemic will require us to take not just an epidemiological or a biological or even a sociological approach to tackling this epidemic, but one which is rooted in equity, one which is rooted in justice, and one which is rooted in truly working with and building new partnerships with our communities. So I wanted to reflect on our journey, both in the UK and specifically in London, when it comes to the impact of the pandemic on the country and the nature of inequalities which we have seen over the past 22 months. Inequalities have been a defining characteristic of our experience in the United Kingdom, and indeed, at the first wave of the pandemic, we were asked in Public Health England to review disparities in risks and outcomes from COVID-19, really looking at who was affected with severe disease and who had increased risk of dying from the infection in the first wave. That initial work really confirmed that there were significant disparities, whether by age, with those who were older age being more likely to have severe disease and death. In wave one, severe and a notable concentration of the epidemic, especially in densely populated urban centres. We saw significant variations by socioeconomic status, with more deprived parts of the country more likely to see severe disease and death from the infection. And of course, in the first wave, we began to see the appearance of disparities by race, ethnicity. Now, when we undertook this work at that time in the first wave, we were keen not only to look at the epidemiological manifestation of the pandemic, but to understand why we were seeing the patterns of disease which were emerging. And so we combined the epidemiological investigation with extensive stakeholder consultation and structured interviews using mixed methodological approaches. And this really helped us to understand those wider social, cultural, behavioral determinants that were underpinning the patterns of disease. And these findings were presented in or beyond the data report. Now, there are a number of ways in which we were able to unpack the data, but it was clear that COVID did not and was not a great leveler in terms of how it influenced and impacted communities. But in fact, long-standing inequalities within society and within communities form the bed and the base and the foundation, both for acquisition of infection, spread, and therefore its negative consequences. So long-standing social and economic deprivation, long-standing challenges with how communities were engaged and included in society meant that there were challenges with how they were able to respond to the epidemic. We also saw that there were challenges in the risks of acquiring the infection, depending on your living status, where you were in terms of your occupation, whether you were in a frontline occupation and job, especially healthcare workers, public transportation workers, etc. These occupations and these roles were more likely to be occupied by members who were either from or living in deprived communities, more likely to be individuals from Black, Asian, and minority ethnic communities. And therefore, we began to see the appearance of risk being associated with different demographic characteristics as well. The qualitative data also highlighted the factors which really resulted in severe disease if you were infected with COVID. And here we saw the impact of poorly controlled long-term conditions, issues related to poor access to and trust to health services, and how those influenced health-seeking behaviors and the willingness of communities to engage with services and to be treated. And then finally, the qualitative work really began to unpack some of the findings on the structural factors which prevents communities from engaging, trusting, and participating both in prevention, treatment, and care services as part of the pandemic response. Issues such as structural racism, discrimination, stigma, and fear of COVID, a fear of being diagnosed with the disease, and the stigma within communities meant that that also had an impact on health-seeking behavior as well. So as the finished, as we moved through the first wave of the epidemic, the key findings from our report really suggested that if we were to mitigate the impact of subsequent waves of the epidemic on different communities, we needed to focus on both a few things and to implement at scale, but to ensure that at every level of government and every level of the system, we were aligned in seeking improvements in key areas. And this slide highlights the 7 key areas that we had and recommended a focus on in order to mitigate some of the impacts of the first wave of the pandemic. And as you've heard from our previous speaker, key among this was ensuring that we had good and better data on key aspects of equalities, including better collection of ethnicity data, better reporting and recording in both clinical and community data sets. We needed to change the way we were doing research to understand the determinants and solutions for tackling the pandemic, including supporting more community participatory research, because we needed to have a better understanding of the social, cultural, structural, economic, and ethical dimensions of the pandemic. We asked for the health services to do much better when it comes to thinking about access, experience, and outcomes of clinical services for COVID. Given the experiences of our communities in the difficulties of navigating the healthcare system to get testing, to participate in contact tracing, or to ensure that they, as we found later in the epidemic, got their vaccines. We had key recommendations on cultural competence as a key intervention for this phase of the pandemic. Cultural competence in the preventive messages which were being delivered, cultural competence in the COVID-related interventions, and of course, as we look towards recovery, cultural competence in how we delivered health promotion programs to tackle some of the underlying health conditions which place communities at risk. This next slide just highlights where we have and how we have evolved with the epidemic in London over the past 22 months. And as you see, we've had both the second wave of the pandemic, which was in the winter of last year. And since July of this year, we have had a relative stabilization at a high level of endemic transmission in the city. Now, key statistics for London are highlighted there on the right-hand side of the slide. In the city, we've had more than 1.2 million people who've tested positive for COVID throughout the course of the pandemic. Today, on every day, we see about 100 patients being admitted to hospital, and at any given time in the city over the past 3 months, we've had about 1,000 COVID patients on the wards, with about 100 to 200 patients in ICU. Now, one of the success stories of the COVID response in the UK has certainly been our vaccination programme. And although rates of uptake of vaccine in London are lower than those nationally, we still have seen significant participation in the vaccination programme in the UK. Sorry. But we do know that despite the success of the vaccination program, that we are seeing significant people who remain unvaccinated in the city. And this really highlights areas where we are seeing challenges with equity and how the equity dimensions of the pandemic continue to play out. So we know that approximately 62% of all those eligible to receive the vaccine in the city have already done so. And there remains about 2.8 million Londoners over the age of 16 who remain to be vaccinated, about 30% of women and just over 35% of men. We also know that the unvaccinated are much more likely to be younger because they're the last cohort to have received their invitations to be vaccinated, but they're perhaps the most mistrustful and the most skeptical of the vaccine program. And they're also most likely to have been exposed naturally to the infection throughout the course of the pandemic. We see significant variations by race, ethnicity as well in the uptake of the vaccine, and this has been a key part of our work in tackling vaccine hesitancy in the city. Some of our deep work then with communities has really helped us to understand what equity dimensions are relevant both to the vaccination program as well as the success of our efforts to promote testing and contact tracing. Some of the key challenges are highlighted on the right-hand side of the chart. nearly 2 years into the pandemic, after intensive work with our communities, we know that there is low trust in state and health authorities due to historic, structural and institutional racial discrimination, underrepresentation, and of course, concerns about unethical medical treatment. We know that there's been significant mistrust in messages and in the messengers, and certainly this has been a key part of the concerted online misinformation campaigns that we've had to deal with over the course of the pandemic. The work on balancing real-world challenges for those who are being vaccinated, getting access to vaccination centres, thinking about difficulties of access, and of course, unfamiliarity with vaccine settings meant that for many communities, getting access to these services was in fact challenging. And of course, there really have been real concerns in communities about low confidence in vaccines, misinformation, concerns about their efficacy, as well as side effects, as well as concerns around fertility. So for all of these challenges over the past year with the vaccination program, we've developed a range of programs and approaches to increase uptake. This has been founded on the foundation of stronger engagement with communities, developing much more culturally competent resources, increasing access by diversifying our vaccination centres, and of course, ensuring that we have robust information being given by trusted sources. I'm going to end the presentation by just thinking and reflecting on the new insights that we've had in terms of engaging communities and building a new infrastructure for not only the COVID vaccine, but the work that we're now doing with the flu vaccination program and listening to communities about what they need to build trust and confidence in services moving forward. We now have better engagement with our targeted groups across the city, many more forums which are engaging locally, hearing the stories of communities, responding in new and innovative ways. We have held a range of vaccine confidence events, which are now evolving into health events, where we're listening to communities and wrapping around other health concerns and health issues which are meaningful to them, and looking at how we integrate and develop a much more holistic approach to our COVID response. We're building infrastructures in communities through health information and health promotion, building bureaus of speakers and new public health ambassadors and COVID champions across the city. We now have hundreds of COVID champions who are engaging in communities, promoting messages on vaccination, protecting health and well-being during the pandemic. And finally, we have strengthened our cultural competent resources, which we are using and have shared nationally, but enable us to do things once within our diverse cities so that all boroughs and all communities can benefit from this. So I'm going to pause there. I want to reflect a bit on our journey with the COVID pandemic in the United Kingdom and to reflect on how the lessons of equity have been applied to our vaccination program. Thank you so much.
We would like to thank you very much for the presentation. And now it will be my pleasure to present Ioan. She's the Director of Medicine, Law and Policy, a group of legal and policy experts offering advice to international organizations and governments. She was the Director of Policy for Médecins Sans Frontières. She has published widely and is the author of several books. For a couple of years, she was listed as one of the 50 most influential people in the intellectual property by the journal Managing Intellectual Property. She has a master's degree in law from the University of Amsterdam and a PhD degree from the University of Groningen, when she remains a global health law fellow at the law faculty. So, in this time of huge challenges, it is my pleasure to invite Ioan to present a small part of her experience and knowledge related to our subject of today. Your floor is yours.
Thank you. Thank you very much for this introduction, and thank you for inviting me to speak at this conference. I have no interest to declare. I'm not paid to be here, and our work work is of a non-for-profit nature. We work for non-for-profit organizations and governments. We sometimes have small grants, sometimes we're paid, often we're not, but we're happy with that. I'll speak today to you about access to COVID-19 vaccines globally and how to ensure access to the know-how needed to produce the vaccines and to deal with the inequity in access that we see today. Now, the COVID-19 pandemic is almost 2 years old, and from the beginning it was apparent that vaccines would be the surest way out of this global health crisis. But it was also clear that such vaccines would have to be available to all on the planet. No one is safe until we are all safe became the mantra that is true at the local level, such as we just heard about the city of London, but that mantra actually is very valid globally, of course. In the early days of the pandemic, we saw a spirit of solidarity, of collaboration, and of an expectation that developing and supplying vaccines would not be business as usual. This time, the world would come together to tackle this health crisis. And we saw that spirit play out in the world of science, in the scientific world. The COVID outbreak led to unprecedented scientific collaboration, open sharing of data and knowledge. Governments gave vast amounts of public financing for research and development. Pre-market commitments became available. In 2020 alone, at least 93 billion euro was spent to help develop products to counter the outbreak. And the first vaccines went to market 9 months after the pandemic was declared. Never before have vaccines gone to market at such a rapid speed. Now, it's fair to say that without this public financing, vaccine development would have been, of course, much slower. Now, while the world of science contributed transparently and in a spirit of collaboration to the knowledge needed to produce these vaccines, there was no mechanism in place to ensure that the resulting manufacturing technologies and intellectual property would be globally accessible. Commercial pharmaceutical companies are now the holders of this manufacturing know-how, the accompanying intellectual property, and the regulatory data needed to produce and bring products to market. And these companies so far refuse to share them outside their trusted circle of contract manufacturers. We also saw a wave of vaccine nationalism leading to hoarding of the vaccines once the vaccines came to market, mostly by high-income countries. But we also saw barriers to trading of vaccines, such as export restrictions by certain countries. Now, COVAX, which was the mechanism that was set up by the World Health Organization, to ensure global equitable distribution of vaccines, was quickly abandoned by rich countries that placed their own orders outside of COVAX to try to get first in line for vaccine supply. Now, COVAX today has difficulty securing sufficient products for supply in low and middle income countries. And the wealthy nations' booster campaigns and campaigns to vaccinate children is, of course, not helping this situation. The limits on production and the hoarding of vaccines by high-income countries has led to grave global inequities and access to COVID-19 vaccines. For example, only enough vaccine has been distributed in Africa to give 2% of the population a single dose, as compared to over 70% of adults in Europe being fully vaccinated with both doses. Now, Dr. Tedros, the head of the World Health Organization, concluded that the rapid development of COVID-19 vaccines is a triumph for science, but their inequitable distribution is a failure of humanity. This current situation is in shrill contrast to the promises made when these vaccines were in their early development phase. If you look back in this short history, you saw several countries that funded the vaccine research committed to ensuring that those vaccines would be global public good. The head of the European Commission, Ursula von der Leyen, publicly stated in April of last year in a joint press conference with the World Health Organization that the vaccines would be our universal common good. President Macron of France said no one will own the vaccine. Further, the promotion of COVID vaccines as global public goods was laid down in the contracts between the European member states and the European Commission, where which contains a negotiating objective. That is the agreement that gave the Commission the mandate to purchase vaccines on behalf of the member states. But that agreement contains the negotiating objective of doing so while promoting the vaccines as global public goods. However, if you then study, which we have done, the contracts that the Commission subsequently entered into with the manufacturers, nowhere is there any evidence that the Commission has actually pursued that negotiating mandate. So the promise of vaccines becoming public global goods remains very much unfulfilled. It did not have to be like that. Early in the pandemic, several initiatives were established to avoid precisely this situation. The World Health Organization in 2020, in May of 2020, established the COVID-19 Technology Access Pool, a place where intellectual property know-how could be shared with others in order to increase the manufacturing capacity. The Medicines Patent Pool expanded its mandate, and later the WHO established mRNA technology transfer hubs to establish new manufacturing of mRNA vaccines in, for example, sub-Saharan Africa. But so far, companies have declined collaboration with the CTAP, with the COVID-19 Technology Access Pool, and with the WHO mRNA hubs. There are a few bright lights in recent weeks. The German drug developer BioNTech has announced collaboration with the WHO on supporting mRNA vaccine manufacture, and the Medicines Patent Pool announced in the last few weeks 2 license agreements for therapeutics, one with Mircea and Dome and one with Pfizer, that would enable generic low-cost production for supply of over 100 countries, which represents about 50% of the world population. Now, these are encouraging developments, but it remains a very meager outcome. Developing countries, low and middle income countries, sort of witnessing the lack of progress with these voluntary mechanisms, have brought the issue to the World Trade Organization and have proposed a waiver of their obligations under the international rules for the protection of intellectual property, the so-called TRIPS agreement. Those negotiations have also stalled and no progress is seen. The European Union objects. It's one of the strongest opponents to the proposed TRIPS waiver, as this is called. The United States is supporting a TRIPS waiver, but for vaccines only. I should mention here that a waiver of intellectual property as such for vaccines will not be enough. You actually need the transfer of the technology. You need a level of collaboration of those that hold that know-how, that manufacturing know-how, that sort of have the playbook of how to produce these vaccines. It's not only about producing the needed vaccine. The key questions is related to the location of the production, the equitable distribution, and the ability to continue to produce for repeat inoculations and boosters. In other words, it's about control of the technology, and that today is gravely inequitable. It could have been regulated very differently. After all, and this is an absolute key point I want to stress in the 30 seconds that I have left, it was public funding that significantly de-risked the company's endeavors to bring these vaccines to market. But governments failed in exchange to secure the sharing of that know-how. And the lack of conditionalities in these publicly funded contracts is a tangible example of a policy failure. In the meantime, of course, COVID-19 vaccines have become big business. The Pfizer vaccine alone accounts for almost half of the company's entire turnover of this year. The total sales of vaccines will be around $124 billion US dollars. In other words, the product has become too big share, perhaps. Now, how can things be done differently? Because what this pandemic has laid bare is the lack of an effective mechanism for the sharing of the intellectual property and manufacturing know-how. And I just want to end with a few recommendations. First of all, public financing of research and development of pandemic countermeasures is absolutely key. That should be ensured, but it needs to come with strings attached to ensure that the knowledge produced with this public financing is not monopolized, but indeed becomes available as a public good. And it would be crucial for the new EU, European Health Emergency Preparedness and Response Authority, or HERA, to put that in place now. To do that once the products go to market is too late. You need to have these conditions formulated early in the process. Second, academia, scientists involved in developing new treatments and vaccines and other health technologies need to think about how they can assure that their innovations become available to all. Today in academia, the norm is valorization, which often leads to exclusive licensing to commercial entities without the necessary conditions attached to it that the technology is shared. This will likely require a change in policy by university technology transfer offices, but this is a conversation worth having. Last, to be better prepared for future outbreaks, the world needs new rules that include measures to assure access to technologies needed to respond to an outbreak, as well as access to the know-how. There is today in Geneva at the World Health Organization, talks have commenced about a pandemic treaty. These pandemic treaty negotiations are scheduled to be discussed at the special session in a few weeks' time, and this offers the opportunity to regulate this better. The area of know-how and intellectual property has been identified as a problem area that does not currently have a regulatory home, so to speak. And it is an area that most likely the pandemic treaty negotiators will have to address. Finally, countries should support, including financially, vaccine manufacturing capacity building and expanding in regions of the world that are currently underserved, such as sub-Saharan Africa, that has almost no vaccine production capacity. It doesn't have to be like that, and that needs to be fixed. I thank you for your attention. Over.
Thank you very much, Ellen Tejon, for that, I would say, provocative message. And I think it's something that we need to listen to, and we need to really discuss also how we can take part in those inequities that you have now just displayed in front of us. So we would like now just to call your attention to the questions which are placed on the screen. The role of a public health practitioner in advancing health equity. What can be done? How can you take part in the debate? And how can you take part in changing health inequality related to community engagement, stigma, quality of care, gender, ethnicity, and so on? So those are the questions that we would like to focus on afterwards. But now, first of all, we would like to have a short round where the other speakers can comment on each other. So maybe since Ellen has just been talking, could I hand over to you, Kevin? Would you like to respond shortly to what you just heard?
Thank you. Yeah, so I want to just thank my two co-presenters for just a fantastic session, and the issue of vaccine equity and global vaccine equity is clearly an important one. I'm not going to comment from a policy perspective, but from the work that we were doing with communities, it was interesting that for many of our migrant communities in the city who had connections to family members or other types of connections overseas, that the issues of how other countries were being treated in terms of access to vaccines and the timeliness of the response also featured in their likelihood to trust both government as well as the vaccine program rollout as well. So there was a direct connection to what was happening internationally, to how communities were feeling and the ways in which they were going to be engaged. And I think there's something there for us as we think about equity in the round, that the equity that we are grappling with is often not only limited to our communities or neighborhoods or cities, but there is that global sense of justice that I think affects all of us in some shape or form. And I think the vaccination program, the access to vaccine has really brought that to a fore. I'm happy to also comment on the first presentation, but I wonder if I should pause here and then.
We'll just give one opportunity also for Rossalina to comment on the last one, if you would like.
Right.
Yeah, thank you very much. I just I don't know if I comment on the last one or the second one, but I just wanted to thank you both, the other presenters, and also Kevin, to underline the importance of having data that could be really disaggregated, because we cannot, as I said in my own presentation, we cannot tackle inequalities and look for equity if we cannot make visible what needs to be done visible, or to be made visible. And this is unfortunately UK, fortunately for UK, but unfortunately for all the other member states, there is information at least for gender, sex and age, but there is no information on many other equality characteristics. And if this information is not available, you cannot even a kind of design targeted measures to tackle, to inform the community at risk, the communities at risk. And I think this is impacting very strongly on trust and also on uptake of vaccine, and also respect of emergency measures when they need to be implemented.
Thank you. Then back to you, Kevin. You could make your second statement if you would like.
So I wanted to thank you, reflect on Rossalina's presentation, because I think, having lived through the pandemic, I started my role in London right at the peak of the pandemic last April. And it was absolutely clear about the need for additional perspectives to be brought around the table, both the policy-making decision table as well as the scientific decision-making tables. Perspectives which were both diverse, which had a wider range of specialties apart from biostatistics, epidemiology, and which included a range of disciplines outside of medicine, and which also included people who are at the grassroots of delivery of programs. So I think as the pandemic has evolved, we have become a lot better in bringing those diverse perspectives to the table, to listening to alternative views, and to ground the response in the realities of communities. And that equity lens has been applied much more consistently as we've moved through the pandemic. So for example, we started our work on vaccine equity in London before the first vaccine was delivered, because we knew, given what happened with testing and contact tracing and the program, that we could see where vaccine inequity would end up and the impact of that, what that would be in the city. So we started engaging, mobilizing communities, doing town hall events before that first vaccine was given. Two other quick reflections on Rossalina's great talk. One of the other things we did in London, in the London response, was to broaden the base of people who were advising us with the response. So we had community leaders, faith leaders, business leaders, we had ethicists, sociologists, behavioral scientists around the table immediately, as soon as we could, to begin to advise on how you took national government policy and made it work for London, a diverse population with multiple needs, real pockets of deprivation in the city, and that need for us to both, in a sense, adapt national policy so that it had a greater sense of effectiveness and impact, but also to use the lens that Rossalina spoke about, the lens of equity, inclusion health, a rights-based approach. That was certainly the language and the approaches that we in London and London partners were able to bring to the table to help to adapt the response in the city. So just to reflect a little bit on that. So thanks, Rossalina.
Thank you very much. Could I just ask Ellen then also to give you an opportunity to respond to the other two speakers, if you would like?
Yeah, thank you very much. And again, thanks for this session. I'm really learning a lot, and it's interesting. Most of my work is at the global level, but when listening to you, I see the same themes emerging, because we're talking about equity, and Rossalina mentioned the need to create trust, and all of that comes down to solidarity. That is very much needed internationally, but also needed at the national and at the local level. And our societies have lost that. As I described in my presentation at the beginning of the pandemic, there was a lot of talk about solidarity, and it wouldn't be business as usual, and the products would be global good, and they would be equitably distributed. A lot of talk, not followed up by measures, and countries retreated into nationalism, even within the European Union, to a level that was absolutely I found shocking. And I think that kind of that also affects how people deal with trust in government, also trust in vaccine programs. So all of that sort of affects, ultimately how effective the response to the pandemic could be. But I think solidarity is absolutely key in achieving greater equity, and that's something that we need to focus on a lot more over.
Thank you so much. And I think it really shows, as you say, this is the same inequity issues coming up in the local municipalities, in the national societies, and globally. And we see they are like exaggerated by a pandemic like this. And of course, the big question for us is, what can we do as public health physicians or practitioners in what different positions we are, young scientists or more senior advisors, whatever we are. So I think that is part of what we really would like to have you engaged in. And those questions that we have asked in the poll, they are about that. So now maybe all of you could pick up your Slidos, and then we'll try and do that poll while we are collecting in questions. And the question that was raised was, do you feel able to promote greater health equity? Number one, I'm not in a position to do much about health inequality. We say inequality and inequity. We were discussing beforehand, but you can take it as the same. The second one, I do not think these issues form part of my work. The third one, I would like to do more, but I don't know how. The fourth option, I would like to do more, but don't want to get involved in politics. And the last one, I am proactive in trying to create more healthy and more health equity. So we'll leave it for a short while so that you have time to squeeze your right button, and then we can read out this and have a short commentary on that as well. I think while people still address those questions, just do a short first question to you, Rossalina, and that has come in the chat box. And that was a question about somebody asking, what is the point of view from Frode around mandatory vaccination?
Yes, I've tried to post the kind of reply. Of course, Frode didn't kind of analyze exactly the mandatory kind of request for vaccination. However, what we've mentioned and what we mentioned in our opinions was that vaccination plans should be in full respect of fundamental rights. There should be a free and informed consent, and I underline that, to have the vaccine. This is linked to the right to personal integrity and also access to rights depending on whether people have been vaccinated or not. For example, if they have the green certificate or vaccine passports, and this is linked to equality as well, equality of access. So this is one thing. And what I would like also to mention is to ensure this. access, equitable access and equal treatment, you need also to, as Kevin mentioned, to have strong participatory approach. And participatory approach means on the one hand to have the affected communities represented, their voice heard and represented in the boards that are counseling or giving advice to government or to implement measures, but also to have human rights, national human rights institutions and kind of human rights bodies to be asked and to give advice, not only to provide scrutiny of the measures that you implement, but to have them on board when you discuss and design further measures. Because throughout the pandemic, at the beginning, human rights institutions were not involved, were not part of the steering bodies. Yeah.
Thank you very much. Should we go back to the poll to see those results that has accumulated there? Okay, the first question there. Do you feel able to promote greater health equity? And the first one, I would like to do more, but don't know how, 37%. The second one, I'm not in a position to do much about health inequality, 27%. I'm proactive in trying to create more health equity, 90%. I would like to do more, but don't want to get involved in politics, 14%. And the last one I cannot see, but that's probably the rest then.
It's very clear that there's a lack of knowing what to do, no? So we need to, Kevin, I hear you breathing.
Yes, I mean, we are public health people, right? We solve society's problems. And if this is an issue of not having the capacity, then it's our responsibility as a community to begin understanding what are our training needs, what sort of mentoring needs do we need to have, what sort of support do we need to have for each other as professionals to be able to bring this aspect of our practice to our day-to-day reality and to our work. So I think this is a challenge for all of us here, looking at the polls to say what more do we do about it. And, yes, it's challenging. And I think, when the initial reports were released on the variations by ethnic groups in the first wave of the pandemic, it was a tough time. Those reports were released at the same time when we were having the global demonstrations on Black Lives Matter movements following the killing of George Floyd. But it was at that moment in time that we needed to demonstrate bravery and leadership on equity issues, whether it was for race or disadvantaged communities or migrant communities or other inclusion groups. So I look at that poll, I'm both challenged and inspired for us to look at those results and say, what more do we need to do to help each other to do better?
Thank you. Any others of the panel who would like to comment? I think Stine.
Yeah, sorry for jumping in, but it reminds me a little bit in the first plenary we had on the first day of EPIET, we had Peter Piert and other experts talking about communicating science. And there was also a poll in which as I remember it, the main point from the audience was that I think the question was, do you address misinformation? It was more directed to communication. And I was really surprised that it was over 70% who said that they might address it with friends and family, but not in public. And I can tell you that in the EPIET alumni community, we have this big WhatsApp group with more than 200 people. And again, today it was full of messages around this topic about many people, the majority, thinking we have to be activists, we have to speak up, we cannot just sit on the data. But there's also the other part, other views raised, such as people feeling exhausted and overwhelmed, having run a marathon for 21 months, not thinking this is their key area of competence and knowing what to do. And then there's the issue of some people working as civil servants in institutions where it's really difficult to speak up. I would be super interested to hear what the panelists think about this.
Come on, Rossalina, please.
Yeah, listening to Stine, I just wanted to mention that this is strongly related also to provision of information and the transparency of decision making. So also information on how decisions have been taken, on the basis of which data. Even looking now back with the fourth wave, now many people are asking themselves, why, for God's sake, being vaccinated, we continue to experience such a strong rise. There was not, for many months, the information was not there and not transparent enough, based on which facts do we communicate now about having the need for third boost vaccination, or why we experience what we experience. So I think it's really important to have a kind of timely provision of information, and to have a transparent information and transparency of decision making, which is provided to the populations on time.
That has come in as a question also to you, Ellen. Would you like to comment on that? The dilemma between having booster doses in Europe and vaccination for children, while you said 2%, I think maybe there might be like 5% in the last figures I saw of Africa now having been given opportunity for the first dose only. How should we tackle this dilemma?
Well, there was, of course, an initiative to prevent this situation, because that was the original idea behind COVAX, was that all countries would be supplied or would procure through that mechanism. And it was based on the vulnerable people first, wherever they were, and certainly giving, for example, a priority to healthcare workers as the first group of people being vaccinated. And you would certainly not want to have a situation where people not at risk or at low risk getting vaccines, while there are large numbers of healthcare workers in the developing world not yet vaccinated. But that did not, because of the vaccine nationalism that kicked in, COVAX was abandoned. And I think this will be one of the issues that the multilateral discussions that are now taking place and the negotiations about a pandemic treaty will have to address. How do you prevent for the future a similar situation? I understand the difficulty of politicians that have a responsibility primarily to the inhabitants of their own country, and the dilemma of deciding to delay boosters in order to make sure that the vaccines are available for countries for people in low-income countries. It's very difficult to do that without having an agreed global framework, and that has really fallen apart. I wanted to make a comment on the poll, because there was one question which 14% of the people answered, I would like to do more, but I don't want to get into politics. But it is important for health professionals to get into politics, and you see the need for much more interaction between the health professionals and the politicians. If I look at Rossalina talked about the communication. If I look at my own country, the Netherlands, where politicians systematically communicate about the pandemic as something that will very soon be over, and there is very little discussion about the fact that we're actually in this for a longer haul, and how are we as a country and as a community going to deal with that. And you can just see that the politicians are not ready to do that. They're just not willing to have that conversation, while in the medical world there's more and more talk about, shouldn't we start talking about this virus? It's going to be with us for a very long time, and how are we going to learn to live with it? So there's these discrepancies that require more interaction and not less. So getting involved in politics will be be important.
Thank you for lifting that. And I think the whole question of inequity is about politics. And the old father Virchow, freely translated by me, he said something like public health is nothing but politics. And politics is nothing but public health. So it goes both ways. And I think that's the way we have to also find our role, not taking the decisions, but advising the decision makers into giving good policies. So I think that's an issue that is really on our plate. Mircea, would you like to pick up a couple of good questions that you found in the chat? I see a hand from Kevin. Is that meant to be, you want to say something again?
Yes, just very briefly, just to support what you said. We have to be realistic, right? So many of us are civil servants, we work within government systems, so it is hard to have that independent voice. But there are ways in which we can use our technical skills, our ability to create partnerships, the networks that we create to be able to both get the work done when it comes to much more equitable responses, but also to empower others to speak on our behalf. And so a key part of the work that we've done, for example, with our community champions, is ensuring that some of the more sensitive issues that need to be discussed in communities, some of the advocacy that needs to be done by communities are best done by those strong community voices. And our role in public health has been to provide evidence, resources, the training that they need to become effective advocates. That was another strategy that we used, even if I wasn't able to be on TV to say, A, B, or C. So being smart about understanding our context, understanding which tools we have available to us, and how we work with our partners, I think are going to be key to addressing inequity in the here and now and in the months to come.
Fine. Mircea.
So there are some questions put to Helen, but maybe all the participants could discuss about. So one, it was if you are able to see any improvement in EU agenda in terms of solidarity for COVID-19 health success, including vaccines, goods, and social medical measures. And another, if there is a way in which the public funds used or that will be used would be used to leverage the companies that hold the intellectual property and manufacturing know-how, and what to do related to this. So the questions were for Helen, but maybe all our speakers could discuss about.
Thank you. Floor is open. Any progress on the EU level? You're working in an EU agency, Rossalina. Are you discussing this in Vienna?
Okay. Yes, I was just looking through the report that I've mentioned, the Fundamental Rights Report Focus Chapter, where one of the opinion, of course, is touching upon the European Commission's proposal for a strong European Health Union. In this proposal, there is a call to adopt that proposal swiftly because this proposal aims to seriously improve the protection of health, but also social and economic life across the EU. So I think there were efforts and also measures on the EU level for this, and yeah, that's what I think that is important to refer to. Yeah.
Thank you. What about you, Ellen?
Yeah, I think I mentioned in my presentation the EU, the HERA, the plans to establish a research and support for research entity along the lines of the US BARDA, which I think will be very important because the public financing going towards where the public health priorities are, and that will be very important in pandemic preparedness and the development of products that are needed. So that has a lot of potential. I think the publicly stated objectives by the European Commission and the European Union to develop products as global public goods is a very first step. And in fact, those two need to be merged somehow, because but just saying something will be a global public good doesn't make it so. You need to then put the mechanisms in place and the rules and regulation in place to ensure that that happens. Of course, if you come with a big money bag, that helps. That is the moment that you do it. We've seen in the last 2 years that has gone wrong. There was a bit of what we call in Dutch a lot of panic soccer being played. Lots of money being spent without it thought through how to condition that spending. And that is something, there's a real opportunity now to get that right. And that is definitely something where public health people could get involved in. And that will have benefits for Europe and benefits, of course, globally, because with infectious diseases like this, you need to tackle things globally. So if you can do that when you establish a new agency like HERA, that would have an enormously important added value. So I'm moderately optimistic that may happen.
That's nice to hear. Could I ask you, Kevin? You've been really working to try and work with the communities in this regard. How would you advise young public health practitioners to engage?
With communities specifically, I think there are 3 key strategies which are important, which is, the work that we do, we didn't start in the pandemic. It's built upon engagement that we've done for tackling HIV, for tackling tuberculosis. We had been developing community-centered approaches to our public health practice for many years. So in fact, COVID allowed us to apply some of those same learnings, some of those networks, some of those strategies to responding to the pandemic. So the first is, let's not wait until another pandemic to start doing the things which we know are right in terms of applying an equity lens to our work. The second is ensuring that we have access to data and we're able to use those data in ways that are meaningful to help us to address what communities need and what policymakers need, especially at the local level. The most equitable response we've had with the pandemic has occurred through local government, working with local communities, working with faith organizations and businesses, because it is at that place where you get the shaping of the response to communities' needs. So getting the data in the right format that can help local partners to act, I think, is key. And then finally, remember that as a result of this, we're creating new networks, new ways of working, new collaborations. It really will be critical that as the epidemic recedes, and I agree with Ellen, we're going to have a long goodbye to this pandemic. But as it recedes, it's important that we don't revert to type, siloed behaviors in our organizations, distancing ourselves from communities and not doing the engagement. We must use the lessons that we've learned from the pandemic to change the way we do business, to change the way we do public health research and the way in which we practice. And that, I think, will be the positive legacy of this pandemic.
Thank you very much. That was a good closing remark from your side. Could we have, if you would like to say anything now at the end, Ellen, it's your turn. This is your last opportunity before we leave over to Stine, because she's been asked to sum up this on behalf of the Alumni Network and herself and us. Any words from you?
I don't have anything to add actually to what I just said. I think there's a lot happening at the European level that offers opportunities to get things right. I also hope that the negotiations on the pandemic treaty indeed kick off. That still remains to be seen, but in a few more weeks there should be a decision by the special session of the World Health Assembly, and I think that pandemic treaty will offer a lot of opportunities to sort of use the lessons learned of the last 2 years and put some new international regulation in place. And clearly that is something that should be of great interest to the public health community. And I'm quite confident that the issues of knowledge and know-how sharing will be central in those discussions. So again, an opportunity that should not be wasted to set things right.
I think that's good you mentioned that. And it's been mentioned, I think, in all those evaluation reports so far. And we've been working on that, I think, from a lot of countries now. And they've been discussing around a lot of tables in Geneva on how they should make this happen, in what kind of modalities they should use to make it a success. So I think we have to be hopeful that a lot of good people are together to really try and sort out that. Finally, Rossalina, do you have a short comment at the end?
Yeah, just a very short comment in relation to the work of civil society organization as well, because they were also in the role to help when there was no access to any other representatives of the communities. And I think it is important to ensure that their civic space and the funding of the civil societies who are really in touch with the communities, if the authorities cannot be in touch with the communities, to ensure that they are safe and they can provide their support. And also because they help to voice the needs of the communities at risk.
Thank you very much. Then over to you, Stine.
Yeah, thank you so much. Wow. Okay, small challenge of trying to sum up. I mean, I think I will start by a big thank you to our three speakers. I have really been looking forward to this session. I'm left with a little bit of this, woof, that went quick, and there's still so much to do and to talk about, but we have to start somewhere. So the points that I noted was the importance of collecting better data. I also wrote, this is maybe only I heard it, but it's something that I hear in my head all the time. We need to go beyond talking. We need to act. We have to, I think, Kevin, you showed us some really nice examples. I know that you couldn't see all of the chat, but there was really a lot of comments also about how people working in other countries wish that they had some of the same initiatives that you presented from London. There's so much still to be done in many places regarding linking to communities and building trust and having a holistic approach. Ellen, I thought your perspectives on the global perspectives and how we really need to keep solidarity in mind. I think that's something that all of us feel are very important. From the poll, I think it became clear that there's still a lot of work to do in terms of helping people, giving them the tools, the public health professionals, the tools, because they would like to do more, but they don't know how. So there's a concrete need for action there. And finally, I was positively, I was happy to hear some of you, Ellen, you mentioned it a few times, signs of positive developments. That made me happy because I must say, with the rising numbers and increasing restrictions and countries that are struggling and responding slow, and a community of public health professionals that are exhausted, and things can look dark. So I think it's nice for us to remember the positive light from time to time. And then, of course, the sentence that we've heard many times, and somehow we tend to forget it, that we need to plan in peacetime. And we really need to work on this when we're not running the marathon. So I really hope we learn that lesson soon, even though we've been told it for many times. So before closing completely, I would say, again, a big thank you to the three of you and to my two co-chairs. I want to remind the audience that there's a bar camp session starting in half an hour, I think, or something, which is really a participant-driven, engaged, open, informal place to continue discussing this. So if you're not completely out of online meeting fatigue, I strongly recommend you to go to that. And also an encouragement to say there's an ESCAIDE evaluation, right? So if you have ideas for topics that you would like to see addressed in the next ESCAIDE, or that you want to keep, that you feel are important, then raise them in the ESCAIDE evaluations. I would give the chance to Frode or Mircea, my co-chairs. I see on our big countdown clock, we still have about a minute. So Frode, Mircea, anything I missed or you want to add?
Thank you very much, Stine. I think that was a good sum up. And I think there is a call for us, everybody, to try and go and also do something with what we think is unjust. And I think this pandemic has showed us there is a lot of unjust ongoing. So let's have that as a credo. Thank you very much for inspiring talks from all of you. And I think it shows that we are in the same kind of situation in Spain, in Romania, in Norway, in the Netherlands, in Austria, and in UK. And I don't know actually where the main office is here now, where the final speaker is taking over. But I would like to say very much thank you from my side as well. Mircea?
Maybe one of the most important messages are what Kevin told a little bit time before, and Stine underlined it too. We need to work in peacetime. We need to be prepared for the next pandemic because it will come. So we need to use all we learned in this time to be prepared for the future. Thank you very much to all the participants and to our keynote speakers. Thank you very much.